Good evening friends, this is Dr. Chaitanya and this is welcome to my channel Critical Care Basics. In this channel we are seeing our ECG tutorials and this is the 35th ECG tutorial. This tutorial is based on WPW syndrome and AVRT part 1. So let's start WPW syndrome. In 1930, Lewis Wolf, Sir John Parkinson and Paul Dudley White published an article about 11 patients who suffered attacks of tachycardia associated with sinus rhythm, ECG pattern of bundle branch block and a short PR interval. Later, anomalous conduction pathway bypassing the AV conduction was discovered and which was called pre-excitation. Now, what is this accessory pathway? In normal heart, atria and ventricles are electrically isolated and any impulse that passes from atria to ventricle has to pass through the AV node. So there is no other way. But in patients with pre-excitation syndrome, there is a congenital accessory tract or bypass tract. And for example, bundle of Kent, and the impulse can bypass AV node and reach the ventricles earlier than the impulse that comes from the AV node and starts ventricular excitation or depolarization earlier, that is called as pre-excitation. This accessory pathway typically conducts the impulse much faster than the AV node. As you all know, the impulse is naturally slowed down, delayed in the AV node. So the impulse from the accessory pathway reaches the ventricles faster and earlier. The impulse can pass in both directions through the accessory pathway, but in some pathways, the impulse can only pass in the retrograde direction, that is from ventricles to atria. Such pathways are called concealed pathways. The terminology of pathways has changed from what it was earlier. Earlier, pathways were named according to the people who described those pathways, but now the pathways are named according to the anatomical site. For example, what was earlier called Kent bundle is now called accessory AV connection or AV bypass tract, shown in red here. The James fibers are atrio-nodal fibers or atriofascicular fibers. Mahem fibers are atriofascicular or nodovascicular or nodoventricular or fasciculoventricular. Similar pathways I have shown in this. For example, this red one is atrioventricular. The purple one is nodoventricular, the blue one, light blue one is fasciculoventricular and the green one is atriofascicular. Now what happens in the WPW syndrome? There is congenital anomalous AV conduction and the supraventricular impulse bypasses the AV node, bundle of His and the conducting system and reaches the ventricle earlier, starting excitation of the ventricles, so that is called as pre-excitation. The ECG changes of WPW syndrome we will see in three parts. The atrial activation. Atrial activation is seen in the ECG in form of the P wave. So atrial activation is essentially normal, so P waves are normal P wave. Ventricular pre-excitation. The impulse passes rapidly through the AP accessory pathway, but once it reaches the ventricles, then it is conducted slowly through the myocardial cells. So the conduction is slow and bizarre, giving rise to a typical bizarre slow wave that is called as the delta wave. And terminal ventricular activation, normally conducted activation catches up, catches up with the pre-excitation front and completes the ventricular activation time in near normal manner. So the terminal QRS complex is normal. So what the final beat you get is the fusion between the pre-excited impulse and the AV nodal impulse in form of a delta wave, mildly widened QRS complex and shortened PR interval. So the ECG changes in WPW syndrome: short PR interval, usually less than 120 milliseconds, slurred and thickened upstroke of QRS complex, the typical delta wave shown in red here, Relatively normal ensuing terminal QRS complex. The terminal part of the QRS complex is essentially normal. The overall QRS complex is slightly widened to about 110 milliseconds, and sometimes there are secondary STT changes, secondary to abnormal interventricular conduction. Same repetition, PR interval less than 120 milliseconds, the typical delta wave, QRS prolongation more than 110 milliseconds, discordant STT changes. Lastly, there is something called a pseudo infarction pattern in up to 70% of patients due to the negatively deflected delta waves in inferior or anterior leads or prominent R waves in V1 to V3. Sometimes you could interpret, a novice could interpret in form of infarction. We'll see an example. For example, this is an ECG in a patient with WPW syndrome. This is a sinus rhythm as evidenced by a P wave which precedes every QRS complex. What is noticeable is very short PR interval, less than 120 milliseconds, that is 3 small squares, and the typical delta wave, slurred, bizarre wave starting just after the end of P wave. Tall R waves and inverted T waves in V1, V2, V3. So if such tall waves are seen in V1, V2, V3, you probably think this is right ventricular hypertrophy or a posterior infarct. But both is wrong. This is a case of WPW syndrome. And lastly, you can see something like a QS pattern in AVL, and you may think in terms of lateral infarct, but this is pseudo infarction pattern in WPW syndrome. There are 2 conditions which also have a pre-excitation, but they are not WPW syndrome. One of the first example, we'll just cover them in 2 slides. First is Lown-Ganong-Levine syndrome. Here there is a pathway of fibers near or inside the AV node which bypass part or whole of the AV node, or sometimes there is an atrio-Hesian pathway, that is the pathway conducting the atria to the bundle of His. And what happens? The impulse is directly delivered from the atria to the bundle of His, shortening the PR interval, but the QRS is normal. So the ECG will show very short QRS PR interval, but the QRS interval is normal, there are no delta waves. So this is Lown-Ganong-Levine syndrome. Another example of pre-excitation which is not WPW is enhanced AV nodal conduction, EAVNC. This is actually, as the name suggests, a faster conduction in the AV node. What happens is there is shortened AV nodal refractory time. And how do you detect this? You cannot detect this on normal ECG, you have to do electrophysiology. In electrophysiology, when you pace the atria and you increase the atrial speed, normally the atrio-Hesian time, the time from taken by the impulse from atria to his bundle of His, it goes on increasing as we increase the atrial rate. But this does not happen in EAVNC. What happens is the AH intervals will remain constant till the time there is a block, that is there is a failure of conduction, that is after a P wave there is no QRS complex. So till the time the AH intervals will remain the same, so that will confirm this is enhanced AV nodal conduction. Now WPW pattern and syndrome are different. If only the ECG is showing WPW pattern but the patient is asymptomatic, then this is WPW pattern. But in WPW syndrome, both the ECG shows the WPW pattern plus the patient has arrhythmia involving the accessory pathway. Now prevalence of WPW syndrome is not very common. About WPW pattern is 0.13 to 0.25 in general population, 1 in 100 or so. WPW pattern on ECG may be intermittent. Sometimes it may be intermittent, it may appear or disappear, sometimes it may permanently disappear. Lastly, this intermittent pre-excitation appears to be in 10 to 40% of all those patients showing the WPW pattern, and only 1.8% of these will actually have arrhythmias. Usually patients with WPW syndrome do not have associated cardiac abnormalities. If there are associated abnormalities, they are mostly right-sided. The most commonly associated with the Epstein's anomaly. In patients with Epstein's anomaly, 10 to 20% patients have more than one accessory tracts, and majority of those are located in the right free wall or right posteroseptal spaces, the right sided tracts. Now this is the cross section at the level of the mitral wall and the tricuspid wall, and you can see that there are so many pathways, like here the right sided, right paraseptal, anteroinferior, anterior, anterior superior, superior anteroseptal. On the left side, left paraseptal, again around the coronary sinus, posterior inferior, posterior, posterior superior, superior. So mid-septal, there are so many pathways, but the most commonly they fall into the four common categories. The right lateral pathway is the most common, 18%. Sorry, right lateral pathway is 18%. The most common is the left lateral pathway, which is 45%. Then posteroseptal, right or left, about 26%, and anteroseptal, right or left, about 9%. Now, what happens to the frontal plane axis? Frontal plane is the coronal plane. What happens to the frontal plane axis or the main QRS axis? If the pathway is right sided, right lateral, then there will be marked left axis deviation. If the pathway is right posteroseptal pathways, right or left, then there will be moderate left axis deviation. If the pathway is anterior paraseptal, then the axis could be normal, and if the pathway is left lateral, then the axis will be rightward, normal to rightward, that is plus 60 to plus 90 in the range. Now henceforth, few slides I have devoted to localization of the accessory pathway. However, if we diagnose WPW pattern or WPW syndrome or arrhythmias in WPW in ICU, we do not require to localize the pathway. That is the job of the electrophysiologist. But there are some pointers to localization that can give us an idea. So we'll not go into great detail because that would be beyond the scope of this lecture, but let's discuss about some common things that are easily noticeable on the ECGs. Pointers to the accessory pathway localization. Leads V4 to V6 will always reflect positive, delta wave and QRS complex wherever the pathway is. Now if the main QRS is dominantly positive in V2, so first you see V2, if it is dominantly positive in V2, it's most likely a left sided pathway. If it is dominantly negative in V2, it's most likely a right sided pathway. Let's see examples. This is a WPW syndrome ECG, P wave normal, short PR interval, typical delta wave. Now in V2 you see a dominantly positive QRS complex. So this is R, big R, small s pattern. So this appears to be a left sided pathway. Again, example of WPW syndrome, short PR interval, delta waves, and dominantly negative pattern in V2. So this appears to be right sided pathway. Now this was, let's see the polarity of QRS in the horizontal plane. So horizontal plane is seen in the chest electrode from V1 to, here we will discuss about V1 to V3 only, because most of the patient will have positive complexes in V4 to V6. So if it is anteroseptal or right lateral, the complexes would be negative in V1, V2, V3, right? So if the complexes are negative in V1, V2, V3, the accessory pathway is either anteroseptal or right lateral, right? In anteroseptal, the axis would be normal, while in right lateral, the axis would be QRS axis, frontal plane axis would be left. In right posteroseptal, I have highlighted this in green because this is typical in the sense that the QRS complex would be negative in V1, but it will become positive in V2, right? The axis would be leftward. So this is typical of right posteroseptal. In left posteroseptal or left lateral, the QRS would be positive in all V1, V2, V3, right? But in posteroseptal, the axis would be leftward, while in left lateral, the axis would be inferior or rightward. In right posterolateral, the delta wave in V1 would be isoelectric or negative. QRS in lead V1 will be dominantly negative, and in V2 would be positive. So in right posterolateral, QRS in lead V1 would be negative, but in V2 would be positive. In left posterolateral, delta wave in V1 will be always positive, QRS in V1 would be dominantly positive, and V2 would be dominantly positive, right? So this is Arruda's algorithm for detection of pathways of different accessory pathways in WPW in ECG. The detailed analysis of this is beyond the scope of this lecture, but this has a sensitivity of 90% and specificity of 99%. So if you use this pathway, you would most likely be able to get an idea about where the accessory pathway could be. Let's see some examples. So this is right posterolateral accessory pathway. The frontal plane delta axis is minus 30 to 60, so axis is leftward. Negative delta waves in 3 AVF and 2. So negative delta waves in 3 AVF and AVF 3 and 2. And frontal plane axis we have already seen left side. Main QRS dominantly negative in V1 to V3. See, so whenever there is dominantly negative delta waves and QRS in V1, V2, V3, it is right-sided problem. In this patient, Epstein's anomaly is associated. For example, you can also see in, you can come to this conclusion by using the Arruda's algorithm. In step 4, the AVF, you can see this is the AVF, positive deflection, and the the QRS complex, I have forgotten to write QRS here. The QRS complex is, the QRS axis is positive, so this is right lateral pathway. Now left lateral pathway, we have seen this example, this ECG earlier in this lecture. So sinus rhythm with short PR interval, dominant R in V1. So you can see dominant R in V1, so this is left sided pathway. And pseudo infarction pattern we have already discussed. If we use the Arruda's algorithm, lead V1 negative or positive, so here predominantly negative, deflection in lead V1, and in lead V1, sorry, in lead 1 it is negative, in lead V1 it is strongly positive, R bias more than 1. So the pathway is in left free wall. Also see AVF, the AVF is positive deflection, so this is left lateral or left anterolateral pathway. Right anterolateral pathway, delta wave is positive in AVF, and because this is right sided pathway, V1, V2, V3 all showing negative delta waves and QRS complexes, the QRS axis is positive and delta wave positive in AVFs. So using this algorithm also you can come to know that this is right anterolateral pathway. Last example, right posteroseptal pathway. This is typical, I have told you. Now negative delta waves in lead 2, 3 AVFs. So the delta axis is negative or QRS axis is negative. So 2, 3 AVF, negative delta waves and positive delta waves QRS complex in lead 1. So axis is strongly negative or left axis deviation. Now typically negative delta wave in V1 and suddenly upright tall delta waves in V2. So this suggests that it is right posteroseptal pathway, and also you can see there is atrial fibrillation in this ECG. Thank you for watching this video. In this video we have covered the WPW syndrome, the pathophysiology, and the localization of the accessory pathway. In the next part, that is part 2, we will consider WPW syndrome related arrhythmias and AVRTs and the treatment. Thank you so much. If you are liking these videos, please like, subscribe and share.